Good evening and very welcome to this webinar from the SEC community from GECO. Professor Russo is a specialist in spine surgery and hip and knee replacement at Paris with a high experience in trauma and polytrauma treatment. He coordinates the educational program for residents in general surgery at Paris. Professor Russo is happy to welcome visitors in his OR to accompany new users and to share experiences. So please start, Professor Russo, with your lecture.
Okay, good evening. Thank you very much, Burkhard. First of all, before I get started, I remind you to click on the button on the right bottom corner of your screen, the polls button. So you have a little survey with two questions. Are you a prosthesis user? And which type of prosthesis do you use? Thank you very much for answering these two questions so we know each other a little bit more. Now I'm going to my talk. This is about cervical disc prosthesis. I'm going to discuss indication and contraindication. If we go back to the early stages, back late in the 2000s, the rationale for disc replacement was based on the rationale for cervical surgery from the anterior side of cervical surgery in general, mainly for in case of neurologic impingement, either radiculopathy or myelopathy associated to some kind of anterior compression, here the disc. So if we have this combination of neurological signs, any type, and discal origin, then there is a rationale for disc arthroplasty. Initially, there was very few exclusion criteria, something very general as pregnancy, former infection, rheumatoid arthritis, those classical contraindications for implantation in orthopedy in general. Then, a few years later, appeared some contraindications like multiple level, prior fusion, adjacent fusion, or any type of systemic disease, even HIV, we can see here. And that's only based on the exclusion criteria of the FDA trials. And there is some kind of confusion between inclusion-exclusion criteria for FDA trials, that are scientific investigations, and indications. Therefore, little by little, it happened to be real that most surgeons were not very satisfied with these restricted indications. And this survey from 2012, about 1,500 members of AO Spine from many countries in the world, showed us that why not doing adjacent segment to a former fusion? Why going into myelopathy? There is some questioning about myelopathy. So the impression is that these criteria are too much restricted. And we have papers from the 2010s. Here is a French paper about multiple level patients. And it shows that those multiple level patients have favorable results compared to one level patient, even 3 level or one case of 4 level patient. On this topic, in this focus, this idea was reinforced by this meta-analysis, and most papers show that there's absolutely no problem using multiple levels. Here is an example of my cases. It's a 2-level discopathy, C5, C6, C6, C7. We went to a double-level disc arthroplasty, and that was fine with some restoration of lordosis. But what I want to say is that, and probably the viscoelastic prosthesis with the ability of binding vertebrae together is a warranty of stability, and there's no point in avoiding multiple levels. This recent paper is a good summary of the situation, showing that it depends on the countries. So if we go on the left, it's the classical contraindications from the US based on the FDA trials. And on the right, here in the middle, is what's going on in France, and on the right in Brazil. And we see that the US, there is a concern about multiple level previous surgery, adjacent fusion. Now, for France and Brazil, there's no contraindication regarding these issues, but it's more the stenosis and the myelopathy, which is questionable. So that leads us to the concept of expanded indication in reference to the US restriction. Multiple level, we discussed that already. The hybrid surgery, meaning a combination of ACDF and disc replacement, is another concern. And this paper is about anterior surgery with a group of patients with only ACDF, multiple level ACDF, and another group of hybrid patients with at least one arthroplasty, might be on top of the others or bottom or the middle level, whatever. But these two groups have maybe the same results at follow-up with the improvement of the neurological signs and the neck pain. This is a case of mine to illustrate the situation. We have a 3-level degeneration with not myelopathy here, but some stenosis in the foramen. And I went to corpectomy with a fusion to remove bone because the two upper levels seem to me to be too much degenerated. But the bottom one was not so bad, and I went to a fusion. So this is an example of a combination of fusion and disc arthroplasty at the same day surgery. The question of the myelopathy is raised on this German paper, though, with the inclusion criteria of clinical symptom of myelopathy with long tract symptoms associated to symptoms on the MRI with the change of the signal of the medulla on the MRI. And the results of this paper shows improvement of the Japanese Orthopedic Association score from 10 to 15. And that's a good example of what we have for the surgery of spinal canal stenosis, if it's from the anterior approach that the stenosis occurs with arthroplasty. That's a case of mine of stenosis with the myelopathy. There are 3 levels involved here. On the right is the lowest level, and we have a severe myelopathy with hypersignal and a severe degeneration. So I did some fusion for the 2 bottom level and the disc arthroplasty on the top level, and that's highly possible. That's why some authors, with all these possibilities, advocate the rationale of using the arthroplasty in most cases. I mean, as much as possible, if it corresponds to the situation. And I could say that I belong to this category. And in this case, they go up to 75% of their case using arthroplasty. The other ones, except the problems of deformity or ineligibility, it's about 15% of their case. They still use ACDF for 15% of their case when the anatomy shows too much degenerated disc, like a very, very small range of motion. In this discussion, it's about 2 degrees, and a very small disc 8 in that discussion is below 3 millimeters. So in that case, the degeneration appears to be too much severe to make an arthroplasty usable, and that's the only case for them for using ACDF. Otherwise, they're fully users of arthroplasty. And this, I have to say that I share this point of view, specifically when we see that long-term studies regarding disc arthroplasty at the cervical spine shows an advantage of arthroplasty over ACDF in terms of results, reoperation rates, and even cost effectiveness in some countries. And that's pretty highly proven in long-term studies. So in a summary, we see that the indication increase little by little because there is very few situations when we cannot use it in arthroplasty. So in my opinion, worldwide, there is, even if we can keep on the side the regulation, we just use the prosthesis on multiple levels. We can use it at a level adjacent to a former fusion with no specific problems. The remaining problem is the excessive degeneration when the disc is absolutely non-mobile, almost fused. Then I have to say that I keep fusion as a surgical solution. Local instability remains in the basket of the contraindication, but there is very few literature about this, and we understand that instability is not a good combination for the arthroplasty, but we can maybe think that the viscoelastic arthroplasty that bind together the vertebra could be a key, maybe used for instability. That's a hypothesis. And finally, the remaining huge non-indication is the isolated neck pain, which is always striking to me because the indication for lumbar prosthesis is back pain. So it's absolutely the contrary in the lumbar and the cervical. So maybe in the future, this consideration may change. But what I want to finish on, this because we are discussing in very detailed indication and contraindications of cervical disc arthroplasty, while most surgeons in the world still use ACDF as their primary indication for anterior cervical spine surgery, mostly based on the access of the arthroplasty. Well, thank you very much for attention, and I'm available for any question in the field.
Thank you very much, Marc-Antoine, for this nice lecture. Are there any questions from the audience and participants to Professor Rousseau? One question I have myself, Marc-Antoine, do you believe that a preoperative degenerative kyphosis could be restored in a normal doses using the CPSP?
The kyphosis and the degeneration in general could be part of the contraindication some way. I think I don't care much about kyphosis when I decide to do a disc arthroplasty because it's not a limitation. And what we see is that with one block implants, such as the SP prosthesis or um, the restoration of the disc 8 and the intrinsic stability of the implant help to restore the kyphosis. We have
Mm.
X-rays showing we have a little more degrees because of the distraction, but also because of the elastic return within the
Mhm.
prosthesis. I would
Okay,
say yes.
okay, thank you. So then we would like to proceed with the lecture from Professor Berg from the Karolinska Institute in Stockholm. There's a question I have. My question more related to the implant. In research, many communities trying to increase life of TDI using surface engineering techniques, coatings, especially articulating surgery. What is your thought about it? Is there any coated disc being tried off?
Well, the question for about the interface between the prosthesis and the bone, I think it's addressed in the presentation of the Shani
Yeah.
Vlasnik at the end. Maybe we switch to the presentation and go back to the question afterwards.
So I think we can proceed with Professor Berg. I would like introduce you. Since over 3 decades of experience as an orthopedic surgeon, Professor Berg has experience in cervical and lumbar disc prosthesis and is now focusing on lumbar. After using different disc prostheses, Dr. Berg has finally set his sight to the ESP disc. He's currently working on an RCT study to compare mechanical and viscoelastic prosthesis. He has implanted hundreds of LPSP in the past years, and Dr. Berg is happy to share his experiences during meetings and to accompany new users.
Thank you, and nice to meet you all attendees. I don't say good evening because all of you doesn't have evening now, since we have it in Europe. I'll first declare my conflicts of interest. I have no current conflicts of interest to disclose, but since I've done this type of surgery with lumbar disc prosthesis in mid-90s, I've been in close contact with most of the manufacturers of disc implants, but does that doesn't give any conflicts of interest. Just widen my experience. When we pick out patients for lumbar disc arthroplasty surgery, this is something that gives superficial results compared to fusions. There are so many published articles on that, so I've not cited them. We know that, but we have to select the patients right. Not only does it give better function, less pain, and so on at both short and long term follow up, but it also give a marked reduction of the risk of ASD, adjacent level disease, in the future. But it's demanding for the patients. They really have to take part in this, and I'll come back to that. So let's start with the patients that are suitable for TDR. We are planning to treat long-standing low back pain that is believed to be caused by lumbar disc degeneration. Compared to the cervical, we accept patients without sciatica or radiating pain. We can treat people that only have low back pain, but several of them also have radiating pain. The patients must have tried physical therapies before we do the surgery. First of all, to know that that is not enough for them, and also to see their interest in taking active part in what's coming. If the patient have a concomitant disc herniation at the segment, it's not the reason we treat the patient, but it's causing problems. Even if low back pain is the main problem, that doesn't present a problem. We deal with both problems at the surgery. We have to think, is this a localized degenerative disc disease in one or a few segments? And if the answer is yes, the patient is candidate for this. We have to see in what shape the facet joints are. If they are severely arthrotic, they shouldn't be treated with a mechanical disc. If they are just slightly arthrotic, we could consider a viscoelastic disc. We have to consider if anterior surgery through the abdomen is possible, and then it's a go. And the question that I come back to is the patient prepared to take responsibility for his or her share of the treatment process? I actually tell my patients that they are going to be my slave for a year. And if they accept that, they're going to do what I tell them. And that is important. That is part of the patient selection. This is examples of two patients that have developed hypolordosis with facet joint arthritis after total disc replacement. If they were treated preoperatively with extensive stretching and prolonging of lumbar muscles and strengthening of abdominal muscles, they should have had a good chance to avoid this problem with the facet joints that doesn't come until a couple of years down the line. So therefore, it's so very important to have the patients working together with you. If the patients have had previous surgery and it's contemporary lumbar herniation surgery, it's not a problem if the facets or lamina are not removed. If they have been through bone decompression, it's probably questionable since the facet joints must have been in bad shape as the reason for the need of decompression. So that would probably not be a suitable case. Previous fusion, yes, when they get their adjacent segment disease, they can very well be candidates for PDR in neighboring segments. So what patients shall we avoid? First, I come back to that. This is third time. Patients that are not willing to do physical therapy prior to reaching you will most likely not do their share of the pre and postoperative activities and restrictions. If the majority of symptoms are due to nerve compression by herniation, it might be a better idea to solve that. Just remove the herniation in microsurgery or something else and see if that removes also most of the problems. Maybe the patient doesn't have a severe low back pain after all. It's the sciatica that is a big problem. We have to deal and think about this. If we cannot localize the painful segments, we have a problem. I use, when I'm in doubt, provocative discographies of degenerated disc. We all know that discography in itself can induce degeneration, but if we use it on already degenerated discs, that is not an ethical problem. Because we need to know exactly if they have 5 degenerated segments in the lumbar, we have to know which of these segments are the ones producing the pain. We don't operate on the MRI scan. And if there is a facet joint arthritis, for mechanical implants, my experience is that they should be virgin, otherwise they will develop a issue with them. With viscoelastic implants, they are more forgiving since there's a counterforce against hypolordosis that helps protecting the facet joints. If there is a spondylolysis, we shall not use total disc replacement. I haven't tried it with a viscoelastic because for me it's a contraindication, but I think it's adventurous to do it. Then we have patients that are not suitable for anterior surgery. They might have a serious scarring after major abdominal surgery, not only an appendix or a gynecological surgery or something like that, but major abdominal surgery. Then it might be something we won't get in again in. They might have ongoing vascular conditions or weakening like Ehlers-Danlos syndrome, which one sort of have very, very weak vascular structures. In Sweden, we don't do this type of surgery if BMI is over 28. That is lower than in other countries, but we feel it increases the risks a lot. It's very complicated to hold everything to the side when the abdomen goes very, very deep. And I have so many motivated patients that have heard that, and then they come back a year later and are in the right side of this border. If they're not motivated to reduce weight, they won't be motivated to do what you ask them to otherwise. On the other hand, the ones that have reduced from 34 to 28, they are my best patients because they obey me even after surgery, and they are so motivated. Then we might have patients with weakened bony structures of end plate, former fracture or osteopenia. That is also a contraindication. This is a patient that had a prior vascular surgery, but as you can see, it was on a height L4, L5, and the patient needed a disc in L5S1, and then there was not a contraindication. But if the disc problems would have been one segment higher, it might be really hard to get there. So a number of patients have contraindication. Are there any left? Yes, a lot of patients are left. But we must remember, as we were told from the cervical, to use a hybrid technique when one or two segments are not suitable for TDR while other segments are. With this thinking and this in mind, there are only a few patients that cannot benefit from preserved maintained mobility at some segments. And the more mobility we can preserve and restore, the better for the long-time results for the patient. So we're really going to try to have as many segments as possible staying mobile. And that's why I do a lot of hybrids too. This is an example of a hybrid with a spondylolisthesis of L5S1, also two degenerative discs on top. And everything is solved from front. And at least the patients have maintained mobility at 2 out of 3 segments. If mobility is earlier sacrificed and led to adjacent segment disease, you can at least restore mobility at the next segment, as shown in this picture. The fusion was like 5-6 years earlier to the TDR surgery. And this is 2 different patients that have the same type of implants in the same segments. But if you look at the left one, you can see that process is shifting over to hypolordosis. And that would put her facet joints in risk. So when I saw this, I started an extensive program. The other patient with a very straight spine does not at all have this risk. Thank you very much for letting me present.
Thank you very much, Svante, for this very thorough and convincing presentation. Are there some questions from the audience and participants? From my point, I would like to ask you, can a patient with DDD at a segment, but also at marked herniation, be treated from anteriorly?
Of course, it's like if you know cervical surgery, that's the way you do it in the cervical, and it's very easy to get. Most of the time when you distract the vertebrae, when you clean the disc out and you distract, in comes the herniation. But if it doesn't, it's easy when you have distracted to just fish it in.
Yeah, this is also my experiences. I do
Yeah.
it in the same manner. No? And would you accept some changes in the facet if using viscoelastic implants?
Yes,
Mhm.
not fully arthrotic, but slight changes, lower cartilage, and so I would accept that.
Mhm. There's a question from the chat. This is a question, can geode or equally shaped end plates be an issue? Is a question for you, I
If
guess.
once again, the shape of the implants, I didn't hear.
Can a geode or cysts or irregular shaped end plates be an issue?
No, not necessarily. You have to be very thorough with cleaning out the end plates to get everything soft, disc
Mhm.
material and cartilage and this and that. So you have a very, very clear bony structure. And if I have a little hole in that, I also takes that soft tissue out from that.
Mhm.
But I don't want to do any harm to the bony structures. And most of the compressive forces, when the disc is placed in the right way, is taken by the posterior ring, where the bone is very strong.
Mhm. Yeah, that's also my mind. Another question is, what do you do if you experience facet joint arthritis after lumbar TDR? Do you consider dynamic posterior stabilization too?
No, I would do a posterior fusion.
Okay.
And that would heal easy as, I'm sorry to say, since I used a lot of mechanical processes, I've had this problem. And they fuse fast because they have such a rigid anterior support as long as I block mobility with my screws.
That's another question from Michael Kontakis. Can one use viscoelastic discs for all these cases since they are more forgiving?
No, there is about the same contraindications, except that I accept a little more wear of the facets. But besides that, it's about the same indications and contraindications. And I started to use it because it was irritating that a couple of percent of my patients came back 5-6 years later with a mechanical disc with facet joint arthritis, even if I tortured them with a program to strengthen abdominal and stretch the back. When I got them out of sight, they didn't continue, and that was the case.
So Martin Seiler is asking, do you know any lumbar TDR that can be placed from lateral, XLIF or TDR? Do you know?
I've been through the era of OMAV, that was oblique Maverick from at that time from Medtronic. It's not there anymore. There was an AMAV too that you put from straight ahead. Now there are, as I understand, another one or two other brands, but I haven't been very enthusiastic since I think it's easy to get in from front, and it's so delicate since it's a mechanical disease, a mechanical device in a mechanical structure, that you get it absolutely where you should, and that is difficult if you come from an oblique direction.
There should be another question. Do you have experienced difficulties while removing a TDR? Did you did it in the past?
I have redone a disc that I've never implanted. I've redone. It's just one letter and one number, the name of it, and I've did a couple of those because they seem to break down frequently, and then they were, most of the time they were collapsed, so they were also loose towards the end plate. It was no difficulties taking it out and replacing it with a more beneficial disc.
Okay, thank you very much, Svante. So I think we can proceed with a lecture from Jean-Yves. Professor Lazenek. Is a surgical practice and teaching are focused on two main interests, which are spine surgery, especially degenerative, correction of deformity, anterior fusion, lumbar and cervical disc arthroplasty, as well as surgery of the lower limb arthroplasty, hip and knee. So Professor Lazenek has also particular expertise in the field of anterior minimal invasive surgery of the cervical and lumbar spine for disc replacement. And Professor Lazenek is happy to welcome all visitors in his operating room and to share his experiences during meetings. So please, Jean-Yves, proceed with your lecture.
This topic may seem strange, but in fact, it is at the frontier of the two previous presentations, I think. The more I was hearing at those two presentations, the more I think it was important to speak about the importance of bone implant interface and sagittal balance. And I shall try to convince this for you. So when we speak about this replacement, we mainly speak about functional performance. It means range of motion, flexion, extension, translation. People don't speak a lot about translation, about share, and the mean center of rotation. And also, we had the opportunity in previous webinar to speak about center of rotation, and we are convinced it is something very important. But it is a functional performance. But in disc replacement, there is another concept, which is the adaptation regarding the vertebral end plates, and it was one of the previous questions, and the influence of the sagittal balance. And most of time, we look at limited X-ray, like this in this example, with flexion extension X-ray. So we are very happy to have good range of motion. We don't analyze very frequently mean center of rotation, and we have few experience about the study of the adaptation of end plate regarding implants. Perhaps you know I am an anatomist, and on the left it is my surgical vision of a cervical disc. We have only an AP view during the surgery, and we are very happy to have good X-ray, perioperative X-ray, no problem. But look on the right, some of my sample, you see the shape of the end plate are very different. we see those end plates from anterior, we don't see them very well as a surface. And we have very different situation regarding the bone density, the cyst in the end plate before surgery. I shall speak about this. And you see the density as in the middle case, you see with a lot of density in some patient, how to deal this surface, because we need to have bone ingrowth in our implant. It is the same thing at the lumbar level. On the left, I am very happy about this disc implantation. I am very happy to have good perioperative X-ray. But the situation are very different. Look at those different discs which were probably black disc. You see the end plate are very different. So perhaps we must open our mind regarding this. When we speak about end plate, we must remember the microanatomy. We have the nucleus, we know vertebral end plate, but inside of this vertebral end plate, you have subchondral bone, sometimes very dense, and as we need to have bone ingrowth and good bone adaptation, we must break this dense subchondral bone without weakening the end plate, of course. And you see there are marrow cavities. Probably you will look in a different way after this, the preoperative CT scan. If you look in a very precise way, you will see that you have small cysts due to liquid inside of the end plate and due to the vascular properties of the end plate. And of course, we shall have different adaptation of the end plate. Mechanical or viscoelastic prostheses are implants. And as hip and knee prosthesis, we have adaptation of the bone stock. Look at those two cases. One case on the left, apparently a silent evolution of the end plate, and on the right, a more dense and reaction of the end plate and a more heterogeneous evolution of the end plate. And the question is, what was the situation before the surgery? So for the preparation of the end plate, it is very important to have a good preparation of the end plate to obtain good bone fusion. But it is not very precise. I want to share some detail with you. It is also important to avoid hypermobility, but what kind of hypermobility? And of course, to have the culture of the radiological follow-up of the bone implant interface. We must convert ourselves in a way to hip and knee surgeon, because hip and knee surgeon have the culture of the follow-up of the patient regarding bone reaction. Look at those patients with long-term follow-up. I did viscoelastic implant like Marc-Antoine since about 15 years, and you see the end plate are not the same. L5S1 end plate very often is relatively silent, and sometimes we may have some radiolucent line, as you can see, for example, in the case 2. Is it dangerous? Is it a problem? We have to speak about this. Look at those X-ray. Most of time now, we look at RMI, but we miss very important thing. Look at the CT scan. It is the same patient, and you see you have a cyst in the end plate, and you have a bone reaction, very different bone reaction anterior and posterior to this disease. How to deal with this? For example, to obtain a good bone fixation, we need to break with the density of the end plate to make the implant communicate with the bone marrow. Personally, I use small pin to do small hole in the end plate, as I do for a cementless cup, for example, when the bone is very stiff and very dense. Of course, we must not create a weakening of the end plate, but doing small holes is, for me, a good solution. So when we put an implant, we need to have at first bone integration, so a good direct contact between the bone soft tissue and the implant without interposition of fibrosis. I think you will see one of the very important message is when I put my implant against the bone, we imagine that the bone remains perfectly in contact with the implant. It's not true. It is very well published that you have immediately a small interpositioning membrane which will be transformed in bone after, but quickly, but not immediately. And then after, we have the step of bone remodeling introduced by changes in load distribution when the prosthesis is implanted into the bone tissue. So two steps, bone integration and bone remodeling. So it's strange. I speak like a hip or a knee surgeon, but it is very important because within the first 2 months, we need to have primary stability. As for a hip, and micro movement have been very well precise for hip. You have here in red the limit for micro movement. So you can say it's very difficult to have a good measurement of those micro movements. Okay, but we must be aware of this. Look at this case, for example, it is a case of mine, 1 month post-op, you see radiolucent line. I probably did not a perfect preparation of the end plate. 6 months, I was a little bit anxious. I asked the patient to wear a small soft brace to limit the mobility. And after 5 years, it was perfectly integrated. So if you have a radiolucent line at the beginning, you must be careful. I am careful. And it is not a failure of the procedure. We must wait because it is biology. And after 1 and 2 years, of course, we have remodeling of bone due to mechanical factor. And of course, in those examples, you see, for example, the bottom case on the left, you had a small slipping of the prosthesis, and then it was locked and with good bone ingrowth, probably because the patient did not respect limitation of mobility and he had a delayed bone integration. So you can say to me, okay, it is theory, but there is a lot of theory about this and a lot of literature. For example, this paper from the HSS journal, the conclusion is mechanical stimulation of periprosthetic bone from fluid, pressure, and flow can induce osteolysis. What does it mean? It means that when you implant a prosthesis, immediately you have periprosthetic membrane. If you have too much mobility, but it is not a huge mobility, but you have progression of fluid between the implant and bone. And as you see on this prosthesis at the top, whatever the brand is, it is not a problem. And you have those small cavity between the end plate and the bone. Does it mean it is finished for this implant? No, because it is biology. And if you are careful, if you ask the patient to be careful regarding mobility, you may have a good final bone ingrowth. This other paper is also very interesting. It is a very well-known paper. Two conclusions: favorable initial condition or a race to surface where osteoblast win should be the goal. I think it is a very important message for us as spine surgeons. The race to the surface, the race to obtain a sufficient contact to have good bone stabilization. And only in the case of hydroxyapatite-coated implant does the motion-induced fibrous membrane convert to bone over time. And we have several papers publishing this, and it is an old concept within 20 years for hip and knee surgeons. So the concept of race to surface. So if you look at those cases, for example, at 2 or 3 years, you see still a small radiolucent line, and all those cases after were followed, and we had good bone integration. And I can show you also those examples. You see 5, 7 years, we publish those cases. You have bone integration. The interface after this is silent. At 7 or 10 years after, we shall see. But today, we can say this. So we have different situations. The good situation, the patient without any reaction of the end plate, and the patient with some density, some small cyst, perhaps because we did not prepare in the good way the end plate, or perhaps because we had a small accumulation of liquid. But is it a big problem? Look at those hip images. Sorry for showing this to you, but it is my common life as a cementless hip surgeon. And you see, there are modification of the bone behind the prosthesis, not because of wear, but because of adaptation. So what are the limitations for mobility? This paper is very interesting because it shows you when you do axial rotation and lateral bending, what are the critical levels. On the left, this paper shows that when you do maximum axial rotation, you may have at L5S1 and L4L5 more or less 4 to 5 degrees rotation in a normal spine. It means that if you don't ask the patient to be a little bit careful to do maximum rotation, you may have normal or delirious rotational movement, which can be a problem for bone integration. It is not for a long time, but it is, as I spoke to you, for the first 4 weeks or 6 weeks. Now, if I do bending, it is interesting also. L4, L5, and L5S1, also you have axial, you have bending angulation. You see 2 degrees. Probably between bending and axial rotation, the most delirious movement to make the patient aware of is axial rotation. I say this to my patients since years. So it is a summary of this very interesting paper you can find. You have a kind of functional scoliosis when you do rotation. Interesting concept. And what about cervical disc? What are the limitations? This paper is also very interesting. In black, flexion, extension, range of motion. In red, lateral bending. And in blue, axial rotation. Very quickly, you see here, when you do flexion extension in black, so you have maximum flexion extension, the most risky level are C4, C5, C5, C6, about 4 degrees for lateral bending and axial rotation. So you can say to me, but it is okay, it is not a lot, but for small bones bridges, it may be a problem. Now we do lateral bending, and you see that 3 levels are more risky, about 6 degrees for rotation. So when I accept that the patient does a lot of lateral bending, I do, despite the ancus, I do rotation, potential rotation at the level of the prosthesis. And now, if I accept the patient to do maximum axial rotation, look at this, you have also at the level of the disc, so at the level of the prosthesis, until 10 degrees bending. So what is the message? The message is not to ask the patient not to move a lot, but it is to be aware of this to avoid delayed bone ingrowth. Now to finish, what about global balance? What are the problems? Patients with high pelvic incidence because they have a lot of mobility in the sacral slope, so more risk of slipping. In the patient, when you have a lot of delordosis, so ask them not to sit too low. In patient with strange mobility at the hip, you see this patient does not sit using fully his hip. Patient with posterior translation of the upper part of the trunk. So patient with a high risk of hypersolicitation for translation. And also patient with pelvic rotation. Look at this patient with a large iliac wing here, a narrow iliac wing here, so you have rotation in the pelvis. Cervical spine to finish, and it was one of the questions to Marc-Antoine. The patient with a low T1 angle, so this type of stiff and kyphotic spine, we must be aware of this, and those patients with hyperlordosis with high level of T1 angulation of the hand plate. So the take-home message, we must be a little bit like hip and knee surgeon. Disc implants require us to think about the intrinsic functional capacity we know, but also their interaction with the recipient bone side. It does not mean limitation of mobility, but we must be aware of small details making our life much better after. Thank you.
Thank you very much, Jean-Guy, for this very, very interesting lecture. From my point, all questions are answered from you. So regarding any thesis of rotation and mobility to avoid the bone-on growth, my question would be, how long do you recommend to wear a brace to avoid any rotational forces after
For,
this?
for the lumbar level, I ask the patient to small, a very small and soft brace for 4 to 6 weeks. If the mind of the patient, it is what Svante explained. If the patient does not follow the regulation and the advices, I ask them to wear the brace a little bit more. It is not with the brace you have still small mobility, but it is the same for the cervical level. In a patient following the advices, I ask them to wear the brace, a soft collar for 10 days, 15 days. But as Tropiano explained us in a previous webinar, in patients without good control, we ask them to be more careful. You see, doing maximum rotation is not nothing.
There's a question from the audience, from Michael Kontakis. Is there a place for lumbar ADI in cases with coronal malalignment, degenerative scoliosis?
For
For DDR?
for for viscoelastic implant, yes, yes. I remember at the beginning of our experience, visiting surgeons were coming to see us, and they were asking the AP view of the patient. We do not understand why, because we don't know abnormal coronal evolution, because they had with mechanical implant. And I have a lot of cases because, of course, we see the problem of the other. And of course, we should have problems, but we don't have those problems. But if you have a patient with an oblique pelvis or with a lot of rotation in the pelvis, be aware, ask them to wear this brace, compensate lumbar leg length discrepancy inequality, compensate this with insoles to avoid this obliquity of the end plate. I skip in my presentation one case with a pelvic obliquity. I think it is very interesting. You don't need to have EOS to see this. With plain X-ray, you can see this.
So I would say the take-home messages we would like to show you our practices are different worldwide based on historical background. The indications increases with the confidence in the technique and evolution of the implants. The questions for oneself before each cervical disc surgery: would a disc prosthesis be an opportunity in this case? And be meticulous when choosing segments that shall stay mobile and be demanding on patients' own responsibilities. As we hip or knee prosthesis disc implants require us to think about both the intrinsic functional capacities and their interaction with the recipient bone site.
Burkhard, there is one question I see that probably is directed to me from Darren Fairley.
Yep.
Is a provocative discography give very accurate results? I've published in the Spine Journal results from a discography study, and the results of that was that the accuracy of choosing segments to treat either with TDR or fusion was largely increased when you use that in dubious cases. It's not that I recommend it as the normal thing for these patients, but if you're very doubtful about what segments to address, I think it's increases your safety and probably success considerably.
And Wayne Connolly is asking, probably to Professor Lazenek, has there been any 7-year follow-up on the 7 years previous follow-up research papers?
Regarding the end plate, yes. We presented a paper last year at the Australian Spine Society, and we are preparing a paper regarding this, but it is with minimum 5 years follow-up. And the idea is to show the patterns of the evolution of the end plate as were published in the old days, the pattern of the evolution of cementless cup on femoral cementless implant. So I took some images of this paper.
And from the Swedish Spine Registry, is anything published from long-term follow-ups?
Yes, I had a doctoral student that were supposed to, before she went pregnant, to publish on the 10-year result from a study that I did in the earlier 2000s. I think I started 2004 or 2003 on the 10-year follow-up between the two groups, and we saw the statistics and over time the distance between fusion and total disc replacement. This was with all mechanical prostheses at that time, but the difference increased over time, since a few of the patients with mechanical discs had to have a fusion because facet joint arthritis, but a big group of the fused patients needed treatment on adjacent segment disease. And already before these complications occurred, the patients were more pain-free and at a higher function with maintained mobility.
So I guess we have reached the time of our webinar now. So I thank you very much, all speakers, and I would say goodbye to all speakers and participants. I thank you very much once more for this interest in our webinar.